having a guest presenter speaking on the topic of DoxyPEP, integrating STI prevention into our public health strategies, including HIV prevention. But before we get started on that topic, we wanted to give an update on the West Region Learning Community group site. So I'm going to have my colleague, Sophia Cass, take over and just give that update first, and then I'll introduce our guest presenter today.
Thank you so much, Jess. Can everyone see my screen?
Yes.
All right. So good morning and welcome again, everyone.
Were you doing the Hep C testing?
My name is Sophia Cass. My pronouns are she.
You don't need a CLIA waiver for that.
Oh, if folks can please mute if you're not speaking, so we don't have back noise. So again, welcome and good morning, everyone. My name is Sophia Cass. My pronouns are she, her, and as Jess mentioned, I am a capacity building assistance coordinator with the Get SFCBA team at the San Francisco Health Department. And so we just wanted to share a brief announcement that all of the previous West Region Learning Community sessions are now available on our group site. And so if
we're at the end though.
Reminders to mute if you're not speaking. Thanks, folks.
And so if you, log in, usually it would ask you your username and password, and this is what your homepage would look like. At the left side of your homepage, you will find the archived sessions page. And so this is where you can actually find all of the previous West Region Learning Community sessions. If you missed one, or if you want to go back and look at some of the materials that you're really interested in, this is where you would find what the session was about, the recording to watch it again, meeting, the session slides, or the material that were showcased during that session. They do go back all the way to when these West Region Learning Community calls were kicked off in September of 2020. And they are sorted in chronological order, which we will also keep updating as these sessions continue to happen. This is also an opportunity for us to remind you all, if you haven't joined our West Region Learning Community, to please let us know, drop your email in the chat, and we're more than happy to send you an invitation. Back to you, Jess.
Thanks so much, Sophia. Okay, so welcome everyone to today's session. I'm going to introduce our guest speaker, and I'll let her take over from there. So today we will be having Dr. Stephanie Cohen joining us. She is the STD controller for San Francisco and the medical director of San Francisco City Clinic, the municipal STI clinic in San Francisco. She's an assistant professor at UCSF in the Division of Infectious Diseases and an HIV primary care provider. Her research focuses on using implementation science to guide the translation of STI and HIV prevention research into clinical and public health practice. And I'll just add that Dr. Cohen is really a leader in the field on these topics, so we're very honored to have her today. Thank you for being with us, and I'll hand it over to you.
Wonderful. Thank you so much, Jess and SEBA team, for the invitation to present to this group today. The title of my talk is Unlocking the Potential of DoxyPEP, Navigating Benefits and Uncertainties. In terms of financial disclosures, I was a co-investigator on the DoxyPEP study, which I'll be talking about today. Doxycycline for the study was provided by Maine Pharmaceuticals, and we received laboratory support for diagnostic testing from Cepheid and Hologic. The learning objectives for today's talk are to describe the key findings of the DoxyPEP study, be aware of key considerations for implementing DoxyPEP in clinical practice, and to be able to describe at least one way that local health departments can support integration of HIV and STI prevention. I know that everyone in this group is aware that the United States is experiencing steep and sustained increases in sexually transmitted infections. These are CDC nationwide data from 2020, and you can see that in that year, there were 1.6 million cases of chlamydia, over 670,000 cases of gonorrhea, over 130,000 cases of syphilis, and 2,148 cases of syphilis among newborns, also known as congenital syphilis, which is a 235% increase since 2016. STIs cause serious morbidity, and when left untreated, can increase risk of transmitting or acquiring HIV infection. They can cause long-term pelvic and abdominal pain and result in the inability to get pregnant and other pregnancy complications. So preventing STIs and turning the tide on our STI epidemic is a critical public health goal. Both nationally and globally, the epidemic of STIs disproportionately impacts men who have sex with men, as well as trans women. These data just illustrate this disparity. The figures on gonorrhea and chlamydia are local from San Francisco, and you can see there that MSM, the blue line, have much higher rates of gonorrhea and chlamydia compared with those of other genders and sexual orientations. The bottom figure on syphilis is from the CDC. Those are nationwide data, again showing the disproportionate impact on MSM. Data for trans women are harder to come by and not as an issue in public health, but this figure here shows that our local epidemic of gonorrhea is disproportionately impacting trans women, and that trans women have been seeing rising rates of GC over the last few years. And then lastly, for context, I think everyone in this group knows that we have made great strides with HIV prevention, with our high impact HIV prevention toolkit, including HIV PrEP. And over the last decade in San Francisco, we've been celebrating declining rates of HIV. But against that backdrop, we're having, as I said, rising rates of STIs. So whenever we talk about the STI epidemic, people's talks end with some statement around new tools to prevent STIs are desperately needed. And with that, investigators, public health practitioners in our community have been looking for innovative strategies. The DoxyPEP study was an attempt to look at a new tool for STI prevention. So why DoxyPEP? The antibiotic doxycycline has shown promise to reduce new sexually transmitted infections when taken after sex or as post-exposure prophylaxis. And also there was a small pilot study done many years ago that looked at doxycycline as pre-exposure prophylaxis, so taking it every day, that showed effectiveness. So this study, the DoxyPEP study, was conducted to understand if taking DoxyPEP after sex would decrease the 3 most common bacterial STIs, as well as to understand the impact of intermittent doxy use on drug resistance, as this is a key concern with using doxycycline to prevent STIs. So why this particular antibiotic? Well, we know from many, many decades of using doxycycline that it's safe, well tolerated. It's also very inexpensive. It's active against chlamydia and syphilis. Going into this study, we know that about 1/4 of gonorrhea isolates in the United States have resistance to tetracyclines, the class of antibiotics that doxy is in. So it was unknown whether or not DoxyPEP would be able to prevent gonorrhea. The design of the DoxyPEP study is shown here. This was an open label study, meaning whether you were in the doxy arm or the non-doxy arm, you knew which arm you were in. There was no placebo. And we looked at taking 200 milligrams of doxycycline as PEP within 72 hours after every condomless oral anal or vaginal sexual contact with a maximum dose of 200 milligrams every 24 hours. This was, in this study, we had two cohorts. So we had folks who were MSM or trans women who were living with HIV, and then a separate cohort of MSM and trans women who were HIV negative and on PrEP. And within each of those groups, participants were randomized in a 2-to-1 fashion to either take DoxyPEP or not take DoxyPEP. The inclusion criteria for this study were being male sex at birth, as I said, living with HIV or on PrEP, having greater than at least one STI in the last 12 months, and having condomless sex with at least one male partner in the past 12 months. During the study, everyone was seen every 3 months, and at those visits, they had STI testing, and the study took place in San Francisco and Seattle at 4 clinical sites, so 2 sites in each city. Oops. Okay, sorry. So the primary endpoint of this study was having at least one STI during a follow-up quarter. And the study was powered, meaning there were enough, the plan was to enroll enough participants to detect a decrease in STI prevalence from 10% to 5%. And when we initially set out on the study, we had a plan to stop the study if in both the HIV cohort and the HIV positive cohort and the HIV negative cohort, we had shown effectiveness based on this thing called a one-sided alpha of 0.025. So in an interim analysis on May 13th, 2022, we had not yet enrolled everyone we planned to enroll, but we stopped to go to our data safety monitoring board and have them look at the data, make sure there weren't any issues going on that might say there was a safety concern, and also to see if we'd already proven effectiveness. And to our excitement, and a little bit to our surprise, we found out that we had already shown effectiveness at that interim analysis. So we stopped enrolling and we stopped randomizing, we stopped enrolling, and we have continued to follow all our participants since May 2022. And everyone who was in the non-doxy arm was offered the opportunity to stay in the study and take doxy if they chose to. This slide shows the characteristics of participants in the study, both for those who were not living with HIV and who were on PrEP, and those who were living with HIV. You can see that the majority of participants were cis men, and a high proportion, everyone had to have had an STI in the past 12 months. You can see that gonorrhea was actually the most common STI that people had had, and in addition, 20% overall had had syphilis in the last 12 months. And the overall median number of sexual partners in the past 3 months was 9. We did this interim analysis, as I said, after we had enrolled 501 participants. And at the time of the analysis, the median follow-up, so the amount of time people had been in the study, was 270 days. And at that point, we had had 18 participants decide to drop out of the study and discontinue. 5 of those were in the DoxyPEP arm, and 13 were in the standard of care or non-doxy arm. And of those 13, 6 decided to stop because they wanted to start taking DoxyPEP. This figure shows us the primary endpoint. So what happened with STI incidence per quarter? And you can see here that we're showing the data for the PrEP cohort on the left and people living with HIV on the right. And within each of these cohorts, you can see the folks on doxy on the left and then standard of care on the right. And so just visually, you can see here this big drop in the proportion of people who had an STI each quarter. And overall, what we found was that DoxyPEP led to a 65% reduction in the risk of STI every quarter. On this figure, you see the same conceptual data, but broken down separately for gonorrhea, chlamydia, and syphilis. And here you can see, and then within gonorrhea and chlamydia, this is broken down by urethral infection, pharyngeal infection, rectal infection, or having an infection at 2 anatomic sites. And so not only did DoxyPEP significantly reduce the risk of having any STI per quarter, we found that there was a significant reduction for gonorrhea, for chlamydia, and syphilis, each separately. In terms of sexual behavior, adherence, and antibiotic use, there was, as I noted, at baseline, participants reported a median of 9 sexual partners and 5 sexual acts per month, and 90% of those sex acts were condomless. There was no significant change in sexual behavior during follow-up in the DoxyPEP arm. In terms of adherence to DoxyPEP, which in biomedical prevention we know is so critical to effectiveness, we found that 86% of participants reported that they always or often took DoxyPEP after anal or vaginal sex, and that the median number of times they took Doxy every month was 4. And a quarter of participants took 10 or more doses of Doxy per month. Those who were in the DoxyPEP arm, because they had a lot less STIs, they also ended up taking a lot less ceftriaxone. And so that's good, right? Because one of the things we were trying to do is decrease the use of the need for other broad spectrum antibiotics for STI treatment. So in the DoxyPEP arm, there was 50% less ceftriaxone use. As I mentioned, one of the critical questions in how and when and whether to use DoxyPEP is this issue of what is its impact on antimicrobial resistance. So there are potential concerns with the impact on STIs and whether STIs could become resistant to doxycycline, as well as the impacts on other bacteria that are in our bodies. So things like Staph aureus, which people are often colonized in the nose, and it can cause skin infections. There's other Neisseria species that are just in our bodies. And then there's the microbiome, which are the bacteria in our gut. And gut health is important for overall health. So there are questions about whether using doxycycline could impact the microbiome and the bacteria in our gut. And we're just at the beginning of unpacking all of these questions. So I'm going to share the data that we have on this at this point in time, primarily focusing on the impact on gonorrhea. And there will be more data to come. So this figure shows the impact in our study of taking DoxyPEP on gonorrhea. The way we do antibiotic resistance testing for gonorrhea is through CDC-funded surveillance projects called SURGE, and testing is done at special labs called ARLN, or Antibiotic Resistant Lab Network labs. And gonorrhea, as many of you may know, is hard to culture. You have to grow it in order to be able to do susceptibility testing. And a lot of gonorrhea is actually diagnosed not by culture, but by something called NAT testing, DNA testing. So we had 17% of our gonorrhea isolates had culture and antibiotic susceptibility testing. So we don't have this for every single GC diagnosis in the study. And as I mentioned at baseline, a quarter, 25% of GC cultures were resistant to tetracycline. And then you can see here during follow-up, we had fewer GC cultures in the DoxyPEP arm because there were fewer cases of gonorrhea. But among those gonorrhea cases, there was slightly higher tetracycline resistance in those who acquired GC while on DoxyPEP. Again, these numbers are small. So what else do we know about this from outside the DoxyPEP study? Well, we know that, for instance, gonorrhea has become resistant to azithromycin when azithro was used as combination therapy for gonorrhea. That increased from 5.8% resistance among men in 2020 and 9.2% 2% resistant among MSM. And there's other analyses that have shown that recent exposure to azithro for GC is associated with azithro-resistant GC. So it's possible that DoxyPEP could similarly promote doxy resistance. We just don't really know yet. So on this slide, I'm going to summarize where we are now. And again, we're still at the beginning of understanding these impacts in terms of DoxyPEP and antimicrobial resistance. We know that historically, antibiotic exposure for GC treatment has driven resistance. Doxy is an important antibiotic option for chlamydia and syphilis. Resistance is not a problem thus far for chlamydia and syphilis, but it's theoretically possible. I have not yet had a chance to talk about Mycoplasma genitalium, but that's another STI for which antimicrobial resistance is already a challenge, and doxy is part of the regimen. And then we have some reassuring data from other settings in which we've used DoxyPEP or DoxyPrep, for instance, to prevent malaria. And in those settings, doxy has not been associated with clinical resistance in Staph aureus. And then in our study, as we already talked about, participants in the DoxyPEP arm were less likely to acquire gonorrhea, but those who did acquire gonorrhea were more likely to have tetracycline resistance. And then I didn't show this data in detail, but similarly, we found that those in the DoxyPEP arm were less likely to be colonized with Staph aureus at 12 months, but of those who did have Staph aureus, they were more likely to be doxy resistant. So a signal, but difficult to tease apart. I mentioned earlier on this concept of the microbiome and this important unanswered question about whether and how DoxyPEP will alter the microbiome. This is a slide from my colleague Colleen Kelly from Emory, who's an expert in the microbiome. And the key points here are that we do think there will be some perturbations in the microbiome with DoxyPEP use, and they will probably be more significant in people with the more DoxyPEP one uses. But to really understand the changes in their impact, it's difficult, very difficult questions to answer. They require very large, very expensive studies. And even if there is a perturbation in the microbiome or a change in the bacteria, we really don't know if those changes would be harmful. Things that have been hypothesized or concerns that have been raised include potential weight gain, effects on mucosal immunity, but these are quite hypothetical and not proven. And as an aside, we did not see weight gain in the DoxyPEP study. So we really need to carefully consider the effects on the microbiome, as we need to carefully consider this in particular in people with HIV, as the effects on the microbiome and gut mucosal immunity may have a greater impact on health in people living with HIV. And then lastly, we already know from some of the work Dr. Kelly and others have done that sexual practices themselves can change the microbiome. And having receptive anal sex has an impact on the microbiome, but there has not been any definitive harmful effects of those changes to date. So really, this is a very tough question in this field. How do we weigh these potential, really theoretical harmful effects on the microbiome with this very significant impact of STI prevention? It's a difficult question. So to summarize where we are now, we know that DoxyPEP works very well to prevent STIs in this study population. It decreased STIs by more than 60% each quarter. And it decreased each bacterial STI, including gonorrhea, which had not been seen in the prior DoxyPEP study. When you think about how the impact that this could have, we found that you only need to treat about 5 people to prevent 1 quarter with an STI. That is a very low number needed to treat for an intervention. And I didn't go through the safety data, but DoxyPEP was very safe and very well tolerated in this study. And at the same time, there's still some unanswered questions and things we don't know. So we don't yet have data on the efficacy and risk-benefit ratio in cis women, but there is a ongoing trial in Kenya called the DPEP study, which is enrolling cis women, and we should have data from that very soon. We also do not have data specifically for trans men or for cis men who have sex with women. We're still investigating the impact on bystander bacteria like Staph aureus and on the microbiome. And we're still trying to understand the potential impact on doxy susceptibility for chlamydia, gonorrhea, syphilis, and mycoplasma genitalium. So with all that, what do we do, right? This is the question we're all grappling with in public health. And so where are we with current state of implementation? The CDC did add a note to the STI treatment guidelines in July 2022 after our initial results were presented at the International AIDS Society conference in July. And so the note you can see here on the slide, and essentially the current CDC STI treatment guidelines do not include a recommendation for or against DoxyPEP. We know that the CDC convened a consultative meeting in the last quarter of 2022 and invited experts to weigh the different questions that I've presented to you today, and is now working on taking that information to develop interim guidelines. The California Department of Public Health is also working on interim guidelines, and some clinicians are prescribing DoxyPEP, mostly on a case-by-case basis. We also know that community interest in DoxyPEP is quite high. So one of the I think questions that everyone is grappling with when we think about DoxyPEP guidelines is, to whom should we be offering DoxyPEP? I shared with you the eligibility criteria for this study. Again, these were men who have sex with men or trans women who had had one or more partners in the last year and one or more bacterial STIs in the past year. So one could argue, well, maybe we should take a more restrictive approach because we want to maximize the benefit risk ratio. We want to minimize excess antibiotic use. And so there's some reasons why I would say we want to treat like the fewest people possible to make a difference. But there's complexities that come with that approach, right? If we have a lot of different rules about who should and shouldn't be offered DoxyPEP. And then there's an argument for maybe taking a broader approach to meet patient demand. There's many people who want to take a proactive approach to their sexual health. And this broader approach also can really have an anti-stigma framework to it, in that we're not requiring people to go through extensive questionnaires, and may help us to address some of the equity issues that we've seen with PrEP rollout. On the other hand, broader use means less optimal antimicrobial stewardship. So this is the tension around the eligibility criteria. And I think I've talked about these pieces. Without a proactive approach, we risk worsening disparities. And so what can we do in this space? Well, we need to generate evidence to guide the approach, but we can't wait for it. We have a very severe epidemic of STIs, and we have a lot of patients and community members who want to start using this tool. So with that, on October 21st, and based on the results of the study and in response to significant and growing community interest, SFDPH released interim guidelines for DoxyPEP. And we knew in San Francisco that we already had many people who were using DoxyPEP and providers that were prescribing it. And so we wanted to provide a framework for safe use of this intervention and to help impact individual health and the STI epidemic in San Francisco. We convened a group of stakeholders and experts in sexual health, HIV and STI prevention, gay men's health, and experts in health equity, and reviewed the data from the DoxyPEP study and developed these interim guidelines, which are available on the SF City Clinic website, as well as our Communicable Disease Control and Prevention website. And our expectation is that these guidelines will evolve as evidence accrues and as CDC and CDPH and other agencies issue guidance as well. So what we decided after this consultation and discussion is that we would recommend DoxyPEP for those who would have qualified for the DoxyPEP study. And we also recommend prioritizing patients who have had a history of syphilis, as this is the STI that's associated with the most significant morbidity for patients. So this is the highest tier recommendation in our interim guidelines. In addition, the consensus amongst our work group was to also offer DoxyPEP to an additional group using shared decision-making, who would not have technically qualified for the study, specifically cis men, trans men, and trans women having multiple partners, but who have not necessarily been diagnosed with an STI in the last year. The committee decided that it was important to broaden the recommendations in this manner to mitigate potential inequities in DoxyPEP rollout, as requiring the STI diagnosis limits this to people who have already been engaging in sexual health services. And we know from our EPI data that incidence of STIs is high in this population, and that number of partners is a strong independent predictor of STI risk. And then lastly, in our guidelines, we acknowledge that at this time, there's insufficient evidence to recommend DoxyPEP for STI prevention for individuals who were reporting receptive vaginal sex. And if used in this group, and if used in people who are able to become pregnant, it's important that pregnancy testing also be considered, since doxycycline use ideally is avoided during pregnancy. So how do you operationalize these guidelines? Well, shared decision-making is a central piece of this. And I think this group knows that high quality counseling is an important component of patient-centered care. What do I say when I say what do I mean when I say patient-centered care? This is care that's respectful and responsive to individual patient preferences, needs, and values. And shared decision-making is a part of patient-centered care. This is a collaborative process that allows patients and their providers to make healthcare decisions together, taking into account the best scientific evidence available, as well as the patient's values and preferences. And it really centers the patient. And there are data that show that shared decision-making is the best method. It acknowledges that the best method for an individual really depends on their preferences and how they weigh risks and benefits. Shared decision-making utilizes motivational interviewing techniques, and it's associated with higher satisfaction with decision-making. And it's especially important when we're operating in a gray area, as we are with DoxyPEP. So what does this look like for DoxyPEP? It means building rapport and trust, eliciting preferences, assisting the patient with a self-assessment of risk, offering enough detail to inform decision-making, and making sure patients know that no decision is final. You can revisit your decision, you can make follow-up plans. So what are some of the key points to cover when counseling a patient about DoxyPEP? Of course, we want to review the key findings from the study so that they understand that this is not 100% effective. This was a 60% reduction in STIs, and ensuring people know that this is safe and well tolerated. It's important that DoxyPEP be recommended as part of a comprehensive package of sexual health services. Certainly, if someone is not living with HIV, DoxyPEP ideally would be offered hand in hand with HIV PrEP. And if someone is living with HIV, it's of course important to ensure that they are engaged and have access to HIV care. STI screening is a part of it, as well as vaccines for sexually transmitted or sexually associated infections like Mpox, meningococcus, hepatitis A and B, and HPV. There are some safety considerations to review with a patient. There are very few drug interactions with Doxy, but there are a couple to consider, and ideally Doxy should not be used at the same time as calcium or multivitamins. It would be spaced separately from those. There's a risk of sun sensitivity. Some patients can get esophagitis or irritation of the throat, so it's recommended to sit upright for 30 minutes after taking Doxy and to drink a lot of water. And there's a rare risk of a uncommon illness called benign intracranial hypertension. So people who develop bad headaches on DoxyPEP should be evaluated. And we want to make sure patients understand the unknowns. So these unknown impacts on the microbiome, on non-STI bacteria. We don't have long-term safety data yet on this, but again, Doxy's been used a lot for other indications for long periods of time. So we do have a one-page info sheet that we are using at San Francisco City Clinic for patients. This is available for download from our SF City Clinic website. And I have this handout broken up into 2 separate slides, but it's a one-page handout. And you can see here reviews for patients. What is DoxyPEP? When should I take it? What do I do if I have sex again? How do I take it? What are we still learning about DoxyPEP? And then, we have some information for our patients about how they can get their refills and what to do when they run out. We also have an infographic available, and I'm sure some of you have seen similar infographics to help patients, to guide patients on how to use 211 PrEP. And so this is adapted from those 211 PrEP infographics and shows how you take DoxyPEP in terms of its timing in relation to sex. So in summary, counseling patients about DoxyPEP requires utilizing shared decision-making to support a patient's choice, guiding self-assessment of risk, reviewing how to use it, acknowledging the unknowns, and offering it as part of a comprehensive package of sexual health services. What are the next steps for DoxyPEP? Well, as I mentioned, we're awaiting CDC guidelines, which are expected by the end of the second quarter of this year. There are several additional studies pending in addition to the Kenya DPEP study. There's ongoing studies in Canada and Australia of DoxyPEP. There's a big need for more implementation science to understand how to implement DoxyPEP that should look at things like interest, uptake, community engagement. What are the best social marketing strategies? How do we educate providers, which I know is a key function of this group? We need additional science to look at the long-term impacts on individual health, the long-term impacts on antimicrobial resistance. And we are looking to starting some collaborations with experts in modeling to really assess the potential impact of this tool on STI incidence in a population. So in thinking about your context in your health departments, I think some of the next steps to consider are just starting some conversations within your jurisdictions, convening local stakeholders to discuss and address concerns, identifying potential champions and early adopters. I think from an equity and disparity standpoint, it's important when you're thinking about implementation in a jurisdiction to have a plan to cover costs for those who are uninsured. DoxyPEP is very, very inexpensive, but we certainly want to ensure that there's access for everyone who could benefit. Considering pilot programs in key settings and planning for provider capacity building. So I want to acknowledge the many people who led and worked on and contributed to the DoxyPEP study, including our principal investigators, Dr. Annie Lukemeyer and Dr. Connie Kellum, as well as my colleagues, Doug Krakauer and Colleen Kelly, who shared some slides for this presentation. And thanks, Jess, to you for the invitation and to the SFDPH CEVA team. I'm happy to answer any questions.
Thank you so much, Dr. Cohen. Wow, that was a whirlwind of great information and recommendations. Do folks want to give some reactions, appreciation? Thank you. And we do have a couple questions in the chat. And for folks who are just ruminating, feel free to start putting questions in. I'll just read off for you, Dr. Cohen. I'm starting out with someone asking, their provider in Southern California is not offering DoxyPEP at this time, nor Apretude. And just wondering if you have thoughts about that for folks who are feeling a hard time with those types of policies, knowing the data that's out there.
Yeah, thank you. That is, I can imagine that would be frustrating as a patient. I think the Apretude question, so for long-acting cabotegravir for PrEP, that is, FDA approved, covered by ADAP. I can't speak to the coverage on every private insurance plan for Apretude, but I think my sense is the main reason why providers haven't yet broadly started offering Apretude is they're like figuring out the implementation pieces of it. That doesn't make it acceptable, but I think patient advocacy is very important to drive providers to offer the service. So I think, I don't know, I don't exactly know why the provider in Southern Cal isn't offering it, but there may be other places where perhaps you could get Apretude. So that one is tricky. I don't know if the various resources on that like the find PrEP provider tools would have information on who is and isn't offering long-acting injectable CAB for PrEP. For DoxyPEP, it's a bit trickier because there are not yet formal guidelines. San Francisco DPH is the only jurisdiction that I'm aware of that has put out interim guidelines. There isn't and will never be an FDA specific indication for Doxy for this purpose. So it would technically be being prescribed off-label. But again, I think patients push us to do the right thing, and patient advocacy is important for driving this innovation. So I think it's great that you've asked your provider for it. And I think helping build a coalition of stakeholders around this will help push health departments and leaders to issue some kind of guidance for its use.
Thank you. We have another question from Jonathan Fuchs. Have researchers looked at changes in the microbiome in groups on long-term doxycycline, such as those with cystic acne? Any lessons to consider as we weigh risks and benefits of scaling DoxyPEP for STI prevention?
Thanks, Dr. Fuchs. That's a great question. I think importantly, you're raising that we have used Doxy for prophylaxis in a variety of other settings. So we're not like entering completely into an unknown here. And acne is a good example of a context in which people have taken Doxy daily for long periods of time. Most of the literature on Doxy in that setting and antimicrobial resistance has looked at the impact on Staph aureus and commensal bacteria. There's not a ton that I have seen on the microbiome itself. Partly that's because research in the microbiome has really exploded more recently, and because microbiome research is really complex and expensive. So unfortunately, I don't think we have a lot from that context to guide us on the microbiome question that can help us weigh the risks and benefits. But I think the other things to consider here are doxycycline for PEP, for STI prevention, is certainly not will never be the primary driver of doxy use in a community, right? Doxy is used to treat lots of other things. Doxy is also used in agriculture, in animal husbandry. So there's like a lot of Doxy out there anyway. So it's hard to really assess how much Doxy for PEP in a focused population will change the overall landscape of Doxy use.
Thank you. We have another question. What type of evidence will be needed to expand DoxyPEP to cis women who report receptive vaginal intercourse and also report using birth control? Are you aware of providers who are offering DoxyPEP to these types of patients? And I guess I'll just add my own small question within that is the DPEP study, to your knowledge, looking at the vaginal microbiome in cis women as an outcome as well?
Great questions. I don't know the answer to your question, Jess. I have not heard any mention of the vaginal microbiome in the DPEP study. So I don't think they are looking at that, but it could be that I just haven't heard that they are looking at it, but I don't think so. I think the key issue, there are two key issues for using DoxyPEP for cis women, and they are really the same two key issues for using it overall, which are like, does it work? What's the effectiveness? And two, are there unique safety considerations in that population? In terms of does it work, it should work, but there's different drug absorption in different body areas, right? And we know with FTC TDF or HIV PrEP that there were differences in how long you needed to be taking PrEP to get to protective levels in the vagina versus the rectum. And so I think it's not impossible that there could be some differences in effectiveness for receptive and protective levels for receptive vaginal sex. So that's the most important finding that we're waiting for from the DPEP study, is showing that in fact, it does protect against acquiring STIs through receptive vaginal sex. And then the safety considerations, I think really the main area where there would be a different safety issue is around pregnancy. And historically, the recommendations around avoiding DoxyPEP in pregnancy have actually loosened a little bit. It's still something that should be avoided during pregnancy, but it's not it's not so unsafe during pregnancy that if someone took a few doses of Doxy, it would be like the end of the world. But that said, contraception in pregnancy testing would need to be an important part of using Doxy in that population. So that's basically, to answer your question, we're waiting for efficacy and safety data from the DPEP study. I do think that there are likely providers who are prescribing DoxyPEP to cis women on a case-by-case basis. If either the patient has requested it and the provider is comfortable with DoxyPEP, or if they're serving a patient who has had recurrent STIs or syphilis and they have a high level of concern around STIs in their individual patient. I'm sure there are providers out there who've done it, but I can't say exactly how many.
Thank you for sharing that perspective. We have a comment from J. Kevin Carmichael. As a state health department employee, I'm not able to really detail around DoxyPEP, absent CDC taking a position. They tell me they're still in development. Although I do tell people about the available research, I also wonder about the recently described gonococcal resistance, if we need to increase ceftriaxone dosing to 1,000 milligrams as is done elsewhere. And feel free to come off mute if you wanted to expand on that too.
I could try to tackle the question unless they want to come off.
Yeah, go ahead. Thanks, Dr.
Okay.
Cohen.
Yeah, I think that this is a great point around not yet being able to proactively detail around DoxyPEP at this point. And I certainly understand and empathize with being in that situation. I think at this point, many of, we're all waiting for CDC and CDPH and other state health departments to issue guidance, because it is going to be critical. DoxyPEP is being used, right? If you look at people's social media profiles and various things, it's out there. So guidance is important to ensure that it's being used in the safest way possible. I think in the meantime, even if you can't proactively detail, we do want to make our resources available to others. So if you have a provider asking you or a patient asking you, at least pointing them to the existing resources is a way to help spread the word. To your question around GC treatment, so you're referencing the recently described GC resistance. So for others on the call who may not have heard about this yet, about 2 weeks ago, Massachusetts released a statement as they identified a case of gonorrhea in the state of Massachusetts that was the gonorrhea was resistant to ceftriaxone as well as to pretty much every other antibiotic. And this is the first isolate of this type that has been identified in the United States. They then did some enhanced surveillance and found one other case with not exactly the same profile, but that also had resistance to ceftriaxone. Both of those patients were successfully cured with the current recommended CDC treatment regimen of 500 milligrams of ceftriaxone. So I think in the level of resistance was not like through the roof to ceftriaxone. But I think your question is good. The CDC is continuously reevaluating the recommended treatment for gonorrhea in response to what's known about patterns of resistance. And so in the most recent iteration of the guidelines in 2020, as this group, most people in this group, many people in this group know, the CDC changed the first line recommended regimen for gonorrhea from ceftriaxone 250 plus 1 gram of azithro to ceftriaxone 500. And whether in the future the dose of ceftriaxone will increase, I think we don't know yet.
Yeah, thanks. I'm sorry I didn't get off mute quick enough. Yeah, I do share your guys' guidelines as part of my discussion of available research. It's just it's interesting as working for the health department now, I've run into times when I want to do things that they sort of say, oh, can't do that yet till the CDC weighs in. So that can be a little bit frustrating. And then with the gonococcal resistance, my concern is just that, in my practice, in 30 years, we rarely get cultures and sensitivities back. And so it actually it almost concerned me more when I heard that yes, it was nice that the people who were treated with the current dosing responded, but you just wonder how many people have increasing, are we getting close to that level where somewhere people are not going to respond? And would you even know necessarily outside of academic settings where you can get a lot more information? So it is a big issue for us. But I appreciate your comments. I really enjoyed the discussion you had of resistance, I hadn't seen that before. So that was really interesting. Thank you.
Yeah, thank you. Thanks for that feedback. The issues around GC are very complicated and important. And you're absolutely right that without culture-based surveillance, we are blind to a lot of what could be going on with gonorrhea. And that's why these CDC-funded projects, SURGE and GISP, are so important to at least have some sentinel surveillance as to what's going on with gonorrhea and throughout the US. So I'm not sure which state department you're from or if there's SURGE or GISP sites near you, but at least they're a way to monitor for this. And there's also efforts to develop molecular resistance tests for gonorrhea, so that we're not only reliant on culture to identify these isolates. But again, it's another reason why with the potential of antibiotic resistant GC in our future, this is like one of the reasons why getting a handle of our STI epidemics, decreasing rates of GC is so important.
Yeah, I'm from Arizona, and of course we're #1 for congenital syphilis, so we've got another big issue. The other thing that I think is interesting, and you may want to comment, is there was some new information, just a press release about a nasal vaccine for gonorrhea, and of course there's older studies and ongoing studies for other vaccinations against gonorrhea. And I know that they're happening, but I don't know really how much. I don't know if there's any data yet, but it's interesting that we may have another tool to approach gonorrhea.
Yeah, that's a great point. I don't have any information on the nasal vaccine, but I can comment on the Neisseria meningitis type B vaccine, Bexsero, which is a vaccine that protects against Neisseria meningitis type B. And that vaccine has been shown to have some protective benefit against Neisseria gonorrhea. And in the one of the current DoxyPEP studies, which is called DoxyVac, which is based in France, in that study, it's a bit of a complex factorial design that they're randomizing people to get DoxyPEP plus this Bexsero vaccine, the Neisseria meningitis type B vaccine, or I think I may have this design not exactly right, but I think it's both versus DoxyPEP alone versus the vaccine alone versus neither. And they are going to be, we think they're going to be releasing interim results at CROI, which is at the end of this month. And they're going to also, their early release is that the vaccine did have quite a significant protective benefit against Neisseria gonorrhea. So yes, I think like vaccines are probably the most impactful tool that we need and don't yet have for STI prevention. And so there's a lot that would need to happen before we could start rolling out Neisseria meningitis type B vaccine for GC prevention, but I think it's a very, very exciting intervention.
Thank you.
Thank you for bringing up that question and discussion. Dr. Cohen, I have a question. You mentioned how health departments can start thinking about this question of DoxyPEP as we await CDC guidance. Do you have any thoughts about how DIS programs in particular might think about DoxyPEP in their work?
That is an excellent question. I think when we think about DoxyPEP implementation, it's really important to think about where are the different settings where it makes sense to implement DoxyPEP, where would you focus your detailing? And I think, the three settings that really come to front of mind for me are HIV care clinics, large HIV PrEP programs, and then DIS partner services programs. So I think particularly for syphilis partner services, most health departments, I don't know of any really that are doing partner services for GC or chlamydia at this point, but to the extent that we're still able to outreach to people diagnosed with syphilis, this is a really great, will be, especially when we have more official guidance, a really excellent tool in place to introduce the concept of DoxyPEP and to link patients to DoxyPEP, just in the same way that we want to have integrated linkage and referral to HIV PrEP into partner services programs. So I think getting DIS up to speed on what DoxyPEP is, how would you counsel a patient about it, to where could you refer them? We're not there yet, right? Because of most places don't have any place to refer someone for DoxyPEP, but we should be building and preparing for that.
Thank you. Do others in the group have any experience with discussing DoxyPEP in their jurisdiction or around programs that are actually offering DoxyPEP? We're hearing informally that folks in many jurisdictions are just starting to have those conversations. Thomas, I see your hand raised. Did you want to come off mute?
Yeah, no, Stephanie, that was great. And I keep hearing it from a community lens. There's a lot of moving parts to it, right? So resistance and who qualifies. And so I'm just trying to, so it's going to be a little bit of a community engagement lift on a good day. My thought though is I keep coming back to the old traditional American motto, more is better. So when people basically ask about using this as a PrEP component, would that lead to less resistance possibility? And is that an option just because the community's gotten so entrenched with the concept of PrEP? And then even that terminology PrEP versus PEP, it's sometimes hard to hear that difference. So I think that's going to be a lot of the dialogue as well. And so I was just how would you respond to that?
Mm-hmm. Yeah, great. Really great question. I have heard that come up as well, Thomas, and I think it's important. I mean, you're just making me realize we should incorporate that specifically into talks on this subject. But I think from an antimicrobial stewardship standpoint, less is more. And the more you take doxy, the higher exposure you have and the greater the risk of antimicrobial resistance. And particularly for like the bystander bacteria, right? So the bacteria on our skin, things like that. I can see how this could be confusing for a patient or for a community member, because with HIV treatment, right, we often will say, oh, you know, if you take your HIV treatment every other day, then you're going to be at risk of getting resistance. So you really want to take it every day. Or like when we're treating an infection, let's say a pneumonia, we're like, you know, you want to take it every day and complete the full course. So I can see where we need to think about messaging to avoid those messages that may potentially seem contradictory. But yes, it would be, in this case, DoxyPEP, lower exposure would be better from the antimicrobial resistance standpoint. The other issue is fortunately, we know that taking it as PEP works. So you don't need to take it for PrEP to get the benefit, because it is effective to take it as PEP. And I think the fact that it's correlated with your sexual activity is, it helps it be titrated to an individual situation. So somebody who's having sex every day is going to take it every day. But if you're only having sex twice a month, you're only going to take it twice a month. So it kind of allows really for that tailored situation. Now, I think your point around people have done really well with daily PrEP is a good one. We have a lot of folks who've gotten into really good routines with daily PrEP. And so it could be like a little confusing. Okay, I do my PrEP daily, but my doxy I only do as PEP. I think we all need to work together to figure out the best ways to like support people around that, right? And then of course, some people use PrEP as 2-1-1, and for them, maybe this will be more intuitive, but it's different because for doxy, you don't do the 2 or the 1-1, it's just 1. So it's a lot. It's a lot to be able to effectively communicate to your patient and ensure that they're understand and are able to kind of follow these different dosing patterns.
I don't know if I missed it while you all were talking, but you're calling this DoxyPEP. Do you guys think that the messaging for this might be a little bit confusing with like PEP for HIV? Just hearing it, like I was thinking about this, but it's take afterwards. Now, like you're just like take you gonna have sex. Especially if you got space. Now the community that we saw. So I'm gonna just try to like.
Freddie, your audio is a little bit in and out. Do you mind typing your question in the chat as well, just so we don't miss it? But I think it was something about messaging with PrEP and DoxyPEP, which I know you were speaking to a little bit before, Dr. Cohen.
Thanks, Jess. Yeah, I couldn't quite catch Freddie's question. So yeah, Freddie, if you can put it in the chat, that would be great.
And maybe in the meantime, I see Dr. Carmichael and Ashley Allison both have their hands raised. So maybe Dr. Carmichael, do you want to go ahead, and Ashley after that?
Thanks. Stephanie, I was curious. I know how to tell people, I explain to people how resistance occurs to HIV because we have an ongoing infection that we need to suppress replication because that's where resistance develops. But I'm not sure that I clearly understand how DoxyPEP is working, in the sense, are we treating an infection before it gets, really established? And I just don't, it's a little, I don't know, how do you address that? I'm curious as to how you do that.
That's a really good question. I think that the theoretical basis for it is that you're getting the antibiotic into the system at the time of, right around the time of exposure to an infection, because we know that these infections, of course, are acquired during sexual activity. And that essentially it's what you said, that the infection hasn't yet taken hold. So the bacterial load is low at that initial time of exposure. And then if one did become infected, then the bacteria replicates and you have more and more bacteria. And so you need more antibiotics for longer to cure. So it's basically having that dose right at the time of exposure before the infection takes hold.
Thanks. Yeah. The other thing I do suggest, and I don't know, you might want to comment or may not, is that I always tell people, people can be, we're exposed to things that our immune systems clean them up without antibiotics at all. And so this is an extra help in the case of an exposure, and it may work for most people. It may not work for you. So you still have to be sensitive to the symptoms and realize even though you're taking DoxyPEP, you can still get an infection.
Yeah, and we're trying to do some analyses of the breakthrough infections. So what were the predictors? If you were in the DoxyPEP arm and you did acquire an STI, what do we know about those cases? Are those, was that more likely to happen in people who reported lower adherence? We know that was the case with HIV PrEP, but we haven't done those analyses yet with DoxyPEP. So I think there's a lot to learn there, but certainly it is really important. It's not 100% effective. I think it's an important point.
Ashley, if you don't mind, just as a follow, can I ask a very quick follow-up to that very same point? So just in terms of an analysis, looking at the timing, so you have within 24 to 72 hours, optimally earlier is better, but do you have a specific analysis that you've done? And I know the numbers are going to still be relatively small, but to be able to look at, does timing matter to be able to prevent infection?
Yeah, I think does timing matter is an important question. And right now we're guiding people, like you said, sooner is better. But the data to back that up, I think we didn't collect the data exactly in that way to be able to do that analysis with DoxyPEP study. So we're going to need, that's going to be one of the implementation science questions that we do need to investigate to better understand how to guide patients. But theoretically, sooner is better. And we do tell people that you have up to 72, but take it as soon as you can.
Thank you.
And then I just have a comment and an observation from my work in Oregon. So I work with the AETC in Oregon, and I've been surprised by how few providers are actually asking about it. And so I've started bringing it up to kind of gauge people's thoughts and feelings about it, providers specifically. And I've just gotten a lot of apprehension, especially with the resistance piece. And so I'm having this realization that this is going to require a significant amount of provider education for people to get to a place where they are contemplating or maybe feel a little bit more comfortable with the concept. And I really liked your comment about where it makes the most sense to implement this type of an intervention, because thinking about partner services and treatment of partners and how frustrated providers feel when they have a patient that's being reinfected by their partner, and the confusion and the counseling that requires, and how that would be such a great tool for them. So I'm seeing that as like an entry point of where it would make sense for providers to start using this, or where it would make the most sense for them to use the tool before they felt kind of helpless.
Yeah, thanks, Ashley. I agree with that. And I think it's helpful to hear it. And yeah, I mean, in terms of provider apprehension, I think you're right. And we think about the early days of HIV PrEP and how much it took initially to get providers on board. And that provider apprehension, I think, came from a lot of different places. Some of it was stigma based. And some of it is, providers are sort of conservative by nature, I think. And I think this is going to be a heavier lift. And PrEP was not an easy lift. So I think like really us as a group thinking through how we're going to get there and what are the messages. And it's every jurisdiction is different. The climate is different. In San Francisco, there's so much community interest and there's already champions. So that word of mouth dissemination of innovation thing really influences other providers to feel comfortable doing this. And I think it's going to take that diffusion of innovation happening in multiple places. And who are the champions that are going to emerge? Who are the thought leaders that are going to emerge? I think we have a lot to learn as this unfolds.
Yeah,
Thank you
I
for
just
bringing
want,
that up. Oh, go
I just
ahead.
wanted to add, based on Ashley's comments, I found it sort of interesting that I find it as a good, it's something new, and providers and people I'm talking about get excited about something new. And so it's a way, something new to talk about, although I can't fully, the CDC issues aside, but it isn't, I find it's a nice, something new to talk about. And that gives me an entree to go back to how much prep are you giving and other things. So it's, I'm actually kind of excited to have something new that they haven't heard about to talk about, because it's more, it gives me my foot in the door a little better.
Thanks for sharing that. I did see that Freddie was able to update their audio, so I wanted to give them a chance to re-ask their question or comment.
Hello. Sorry you guys couldn't hear me earlier. I think I got a little bit more clarity by some of the responses that people were giving, but I was just wondering, because it says DoxyPEP, and I know a lot of times people right now, like a lot of the community that we work with, especially communities of color, like they still get the confusion between PrEP and PEP. What are they going to be doing to make the distinction that this is not the same thing from those two medicines? And how are they going to address pill fatigue?
Yeah, thank you, Freddie. Those are great points. We need some creative minds in the branding and the naming here. It's like now we have three things. They all sound kind of the same. So I don't have a good answer for you, but I think it is, we need some creativity here to avoid that confusion that you're understandably like anticipating will happen. And pill fatigue also, is certainly an issue. We're throwing another pill at people, and how are people going to feel about that? And how do we address that? It's a good question.
Okay, we have one more minute. Thomas, do you have a short question or comment? And then Frank has an announcement before we wrap up.
Sure. Just with regards to the resistance issue, and maybe there's not an answer to it, but just as somebody who's never had to make a new drug, like if people kind of throw that out there, it's like, how challenging is it to find something new that would, if you understand my question.
Yeah, very challenging,
Okay.
very hundreds of millions of dollars challenging. But yeah, an antibiotic pipeline is an issue broadly in infectious diseases. Pharmaceutical companies don't really want to invest in that. They want to invest in like big blockbuster lifestyle drugs that are going to make a lot of money. So our lack of an antibiotic pipeline is like a big issue. And generally speaking, when there are new antibiotics in the pipeline, they're studied specifically for like one prevention of or treatment of kind of one thing. So I don't know, but I think it's unlikely that there would be new options, new antibiotics that are not yet out there for this. But there could be other existing antibiotics that could work.
Oh,
But Doxy is ideal kind of for all the reasons I mentioned.
Thank you for bringing that up. Frank, can we hand it over to you for our announcement and one last round of responses and gratitude to Dr. Cohen for her presentation and staying with us for this interesting discussion. And thanks to everyone, all our participants as well. All right, go ahead, Frank.
Thank you all for joining us. And I just wanted to make an announcement about our Public Health Detailing Institute coming up at the end of March. It is March 29th, 30th, and 31st. It's 2.5 days. And we will be discussing about having a focus on syndemics. In the past, we've focused on PrEP, but this year we will be incorporating other topics, including DoxyPEP, as well as Hep C and syphilis, and detailing for opioids. So there's a link in the chat, but if anyone is interested in participating in that, you can email me or Jess or our team at getsfceba@sfdph.org and let us know if you're interested. So just wanted to make sure I told you all about that.
Thank you. All right. Thank you to everyone who participated. Thank you to Dr. Cohen for her wonderful presentation, and see you all in a few weeks for our next session.
Take care. Thank you all.
Thanks all. Take care.
Thank you.